في شركه جديده نازله بعدين لي تراكيوستومي شركه جديده نازله.
مش موضوع السايز بس، السايز موجود على فكره افيلبل، مش في كل المستشفيات طبعا. هي القضيه الاساسيه اكشولي ان معظم التيوبس عندنا، التيوبس اللي المفروض تبقى موجوده في الانتنسيف كير سواء كبار او صغيرين، حاجه بنسميها هاي لود. الهاي لود اللي هي هاي فوليوم لو بريشر، مش متوفرين في كل المستشفيات، ودول بيبقوا اقل حدوثا للسبلوتيك ستينوسس. الحاجه الثانيه حضرتك عارفه العين هو التيوب موجوده والفنتليتور بوشنج باك اند فورث، فده بيعمل انجري سبلوتيك ميكروزا، فده بيزود عشان كده دايما بنقول نسرع بعمل التراكيوستومي. سايزز ار افيلبل شور 100% موجودين.
لا وفي حاجات انا فوجئت ان اتفضل.
السايز بتاعت التراكيوستومي تيوب هي اللي مش موجوده.
لا يا فندم موجودين.
التراكيوستومي تيوب
يس
يعني احنا باستمرار كنا بنبعت
يقولوا ما ديبندز حضرتك وير يو براكتس. انا اسف تو سي ذات بس السايز موجود، الشركات موجوده حضرتك.
شكرا.
لا والتكنولوجي بقى ده هو كان بيكلمني اصلا على دي مشكله على التوتال لارنجكتومي بتسموه لارنجكتومي، شايل وعندهم ديفايسز بقى ويتكلموا من غير ما لا انا بتكلم على بدايه الكلام كان كده، بدايه الكلام على دي، وبعدين
السبيتش فالف موجود من زمان
بس منزلين حاجات جديده خالص. فظيع. هبعت لك دول ماشي.
المحاضره جايه او الدكتور جايه باستاذه دكتوره ساميه بسيوني هتتكلم. دكتوره ساميه بسيوني هتكلمنا على اسسمنت مانجمنت فيدنج اند swallowing disorders. تتفضل دكتوره ساميه.
Thank you, Mr. Chairman. Good morning, ladies and gentlemen. My name is Samia Bassiouny. I'm a professor of phoniatrics and swallowing disorders at Shams University. I will talk about assessment and management of swallowing and feeding disorders in pediatrics. Actually, we receive several referrals from the pediatric department and the NICU for infants who need feeding and swallowing assessment. Feeding disorders are defined as problems with eating, so we have to differentiate feeding disorder or a swallowing disorder. Feeding disorder entails with no sucking or weak suckling during breastfeeding or bottle feeding. دكتورة صفاء ليها كلمة يعني مشهورة، يا دكتورة سامية الولاد دول بيتولدوا ما بيعرفوش يرضعوا ليه؟ We have to differentiate, is it a feeding disorder or a swallowing disorder? So we're talking here about inefficient feeding, but for swallowing disorder, problems with one or more phases of swallowing, which we are talking about aspiration and later on aspiration pneumonia. So we're talking here about the safety of the swallow. The swallowing phases and related problems, according to Arvidsson, 2008, oral preparatory phase here, inadequate lip closure and disturbed tongue movements result in sucking problems and loss of food from the mouth. Oral transport phase here, if we say here, oral transport phase, problems with the bolus formation itself and reduced tongue strength and poor posterior propulsion of the bolus in order to propel the bolus posteriorly to the posterior pharyngeal wall and delay in the initiation of the swallow itself. Pharyngeal phase problems, nasal regurg of the food, penetration and laryngeal aspiration, residue after the swallow, whether valliculi or the pyramiform fossae, or reduced pharyngeal contractions. Esophageal phase disorders entail esophageal motility disorders and gastroesophageal reflux. What are the presentations of food feeding and swallowing disorders? Airway or respiratory problems, alterations in breathing, tachypnea, apnea or bradycardia during feeding itself, frequent coughing during feeding and choking, noisy breathing or crying, circumoral cyanosis, prolonged feeding times, fatigability during the feeding time, weight gain is a concern, and delayed progression of oral feeding skills. Of course, this will lead to delayed hospital discharge, and there is a concern of gastrostomy and nasogastric tube insertion. The etiology, we encounter a lot of cases with feeding and disorders and swallowing disorders such as cerebral palsy, prematurity, and immature neuromuscular control of feeding, which leads to decreased hyolaryngeal excursion of the hyoid and the laryngeal cartilages and lead to penetration and aspiration with or without prematurity. Anatomical structures which are congenital abnormalities, laryngomalacia, cleft lips that like the one that was showed by Dr. Ahmed, bilateral vocal fold paralysis, subglottic stenosis, tongue tie, tracheoesophageal fistula, esophageal atresia, and cleft lip and palate, whether unilateral or bilateral, complete or incomplete. Down syndrome, of course, organic golden heart syndrome, systematic disease such as gastroesophageal reflux, respiratory, chronic lung disease, cardiac disease, and social and behavioral issues during the feeding time. What about the pathophysiology of those feeding difficulties? Neurological immaturity due to the underdeveloped CNS may lead to feeding problems with inability to suck or slow and weak sucking, and inability to coordinate suckling and swallowing and breathing, which is supposed to be disappear at 37th week, which could lead to episodes of desaturation, apnea, and dehydration, and bradycardia and aspiration. And difficult transition, of course, from oral feeding to tube feeding. The pathophysiology here, the cricopharyngeus muscle, which is located in the upper part of the esophagus, it should relax 0.1 of a second to allow hyolaryngeal excursion. But this doesn't happen actually in premature infants. This muscle does not relax, like here. It should go like this very smoothly and very smoothly in very nice coordination. But this immature neuromuscular control will lead to aspiration because of difficult hyolaryngeal excursion. So this is a spasm in the upper esophageal segment and it's not able to relax. The consequences of those feeding problems, the unpleasant medical procedures carried out in the NICU with the nasopharyngeal suctioning, endotracheal intubation, insertion of oral and nasal feeding tubes and tapes, and the noise in the NICU may have a negative effect on the baby and development of the oral motor control and sensation, and later on they develop oral aversion and long-term feeding problems. Remember Dr. Osama, this thing which we're talking about. We've just seen a case with severe oral aversion because of refusal of food. So you can encounter those patients. And poor weight gain, aspiration pneumonia, and delay in transition of the hospital discharge. Actually, 40% of those patients followed in the feeding and swallowing clinics are former preterm infants. If left unresolved, they turn to have oral food aversion and long-term feeding difficulties later on. So in later on, they come with eating disorders of early childhood with a lot of synonyms according to the Diagnostic Statistical Manual, DSM-5, 2013, with a lot of names: benign picky eating, tactile defensiveness, functional dysphagia, neophobia, sensory food aversion, toddler anorexia, food avoidance emotional disorder. They are all different than the anorexia nervosa and the bulimia that Diana Spencer had. These are for older cases, but this is for eating disorders of early childhood. So you can encounter those after a long experience of feeding and swallowing disorder in the NICU or after that. Eating disorders, it can present itself a behavioral disturbance during the meal time, the meal, gagging, a lot of gagging, a lot of vomiting, a neophobia, refusal of any kind of new food, and strong food preferences, limiting quantity or quality of food, and only on soft or blended food. Remember that, Dr. Mariam, this is your patient. She was 2 years and only on soft or blended foods for 2 years, and actually she was about to do gastrostomy because there was a concern of the weight gain, and she had hypoglycemia. She wanted in attacks of hypoglycemia because of inability to eat. So there are patients out there having those problems. Hypersensitivities, I will show you this case. She's able to chew and swallow, but see her action for the food. She's always having gagging and vomiting. At the end, she will vomit, but always repeated gagging, gagging, gagging whenever she had chewing on her food. So this is considered hypersensitivity. She has severe hypersensitivity for food. A slightest touch for her mouth, she brings gagging, and at the end she has vomiting. When it comes to the assessment and treatment, it's actually designed to promote safe and efficient swallowing, and reaching oral feeding for preterm infant and newborn is one of the prerequisites for NICU and hospital discharge. So there is a teamwork, the multidisciplinary approach, pediatrician, neonatologist, phoniatrician, clinical dietitian, lactation consultant, neurologist, plastic or ENT surgeon, and pediatric surgeons. Actually, that was a conference held in Dubai for the eating disorders of early childhood, and this was a clinical dietitian coming from Australia, just to share with her expertise in clinical, how to maneuver or how to manage the clinical diet for these children. This is the picture of the conference. The food is there, and he's not able to have his food, and not able to open his mouth. Even the slightest sight and the smell of the food can produce gagging and vomiting for the child. So we begin actually with a bedside assessment to see if there is a nasogastric tube or gastrostomy and so on, if there is amount of supplemented oxygen, if the patient needs that in the NICU, any supportive action by the caregiver, the management of saliva, if the patient needs repeated suction. Red flags, questions to ask the caregiver or the nurse: signs of airway, respiratory problems, increased respiratory rate or effort during the meal time, prolonged feeding times, history of weight loss, lack of weight gain, fatigability during the meal, stress at meal times, inability to coordinate sucking, swallowing, breathing, which Dr. Ahmed showed us, symptoms of aspiration, coughing or choking during the meal time, and change of the voice quality. We have to ask all of those questions, and there are neonatal feeding assessment tools out there in the literature. So the most common ones are the early feeding skills tool and the NOMAS, normal neonatal oral motor assessment skill. So we begin actually with the trial feeding, giving the child whether breast milk or the bottle, and observe pre-feeding baseline, oral feeding readiness, ability to maintain engagement during the feed, ability to organize oral motor function during the feed itself, and the baseline after finishing the bottle. Saliva management, tongue mobility during the feeding itself, nasal regurg, if any, coming out of the nose, coughing or choking, and the voice quality during the feeding. Other bradycardia, tachypnea, pallor, and so on. And the post-vital signs. Like this patient, actually was able to swallow, but actually whenever he was fed, he enters in bradycardia, apnea, and desaturation, and he stops. But there is no aspiration. But whenever he's fed, he produces those stress and subcostal, intercostal, and interactions, and subcostal, and fussy and crying and worried look. But he was not able to get out of the NICU, and he was on the nasogastric tube for 3 months. But there is no aspiration, but he is a feeding problem. Only feeding problem. He was not able to be discharged from NICU on the nasogastric tube. So whenever he was fed, he developed the stress cues. We also evaluate the non-nutritive sucking evaluation on the pacifier, the rooting reaction, easy beginning of the sucking, and the tongue central groove, and peristaltic tongue mobility, and so on. And the disadvantages of the bedside clinical assessment is it can 40% of those patients can be silent aspirators. So you can miss 40% of those cases who have aspiration, and it's not apparent during the examination. So you can miss them quite easily. So that's why we resort to videofluoroscopy and videoendoscopy. This is the upright position during the videofluoroscopy, and the patient is taking the bottle feeding very easily and in the very natural situation. This is a milk mixed with gastrographene given through a bottle feeding or a syringe or a spoon, whatever. And then, so these are the presentations, formula through a bottle, syringe, and spoon with different volumes and consistencies according to the age of the child. And this is our famous Samia patient who had also been in the NICU for 3 months, and she was examined actually with a nasogastric tube, and the problem of her positioning was for me to have the anterior-posterior position in order to watch the symmetries of the pharyngeal contractions, and she was so little to be held in the upright position and held her head in order to show the whole pharynx and esophagus down to the stomach in this position. So actually we managed to carry her, and then she was examined. So this is the problem of positioning. Those consistencies according to the age, thin and thick and semi-solid and solids, and then this is the monitor room. You can observe the swallowing during examination, and you can have them on a CD or through the mobile. And you can observe during the swallowing all of the items or the phases of the swallowing, the pharyngeal phase, esophageal phase, and oral phase quite easily. And you have a checklist, of course, for the modified barium swallow, commenting upon the oral phase, pharyngeal phase, esophageal phase, any laryngeal penetration and aspiration, and why is it happening actually, and the timing of the aspiration, whether it's before the swallow or during the swallow or after the swallow, and any residue, if there is residue in the valleculae or the pyriform fossae. And this is the timing. Actually, the delay triggering of the swallow reflects the one that Dr. Ahmed showed us. The delay triggering, actually, it's quite safe. But whenever the child is given larger amounts to be fed, he can develop aspiration and enter the trachea. So the problem is not the quantity, and it's the timing. Of course, if there is a delay triggering, you better hurry up to give him instead of going to aspiration, because of the larger amounts could be swallowed during this reflex delay. Like this patient is having this bottle feeding and having very minor aspiration in the trachea, so you have to observe the timing of the aspiration and why is it happening. Like this patient had bilateral vocal fold abductor paralysis, and he was sent from the ENT surgeon in order to see if he has aspiration or not with the bilateral abductor vocal fold paralysis. And here you can see there is no aspiration and the trachea is free, and just the bilateral abductor paralysis left with. This patient had also a laryngeal cleft, like the ones that Dr. Ahmed showed us, and actually he was having aspiration during the feeding, and this is a large cleft considered reaching to the level of the vocal folds, so we have to watch out, and his surgeon referred him because of the fear of aspiration and getting aspiration pneumonia because of this laryngeal cleft. This is another laryngeal cleft for 1.5 years old, and you can observe from the trickling through the posterior wall of the trachea and going to the anterior wall and through the laryngeal cleft posteriorly to anteriorly. This is another patient with spinal muscular atrophy. He was one of the patients who had the very expensive 1 million Egyptian pounds injection through مش عارفه بتاعت السيسي حاجه كده تبع السيسي، ان هو مش يعني كده مبادره السيسي للاطفال دول، اخذ الحقنه. Actually, he had severe cricopharyngeal dysfunction. As you can see, nothing was entering the esophagus, and it affected only the cricopharyngeus beside the muscles, other muscles in the body. And we had the decision, of course, unfortunately, to do gastrostomy because he was not able to handle the nasogastric tube for more than 2 months. So we decided to give him gastrostomy. But the good news is that he had regained the oral feeding after 1 year of the gastrostomy. He was able to carry on to have the oral feeding after the gastrostomy. So we have to follow up those cases very, very tightly. Another case, This is Somaya also with her, she had laryngomalacia and the fees was normal and the videofluoroscopy was normal and she didn't have any aspiration. That's why there was a challenge between Dr. Shadia and Dr. Mariam and Dr. Amani Rida in the NICU whether to give her gastrostomy or not, but she did not have any aspiration. That's why we said we have to go on to manage compensatory strategies and with a motor sensory exercise until she was discharged from the NICU after 3 months of using the nasogastric tube. Videoendoscopy is the same by passing an endoscope through the nasal cavity, and this is the upright position in the videoendoscopy. It has a lot of advantages, but the disadvantages is no direct assessment of the oral phase and the esophageal phase, but pharyngeal only. But actually, whenever there is a white out during the swallow itself, there is complete cessation and you cannot see what's happening and what's going on during the swallow itself. So it shows before or after, but not during. And the fast swallows of the child during the panic cry that he has during the swallow, it gives you false positive results that he has aspiration. When you do the videofluoroscopy at ease, it doesn't show you the false positive. It gives you the actual happening of the aspiration. That's why I'm totally biased for videofluoroscopy rather than videoendoscopy. And again, it shows you the valleculae and the pyriform fossae and the opening of the larynx and the pyriform fossae and the residue, whether the location of the residue, the valleculae or the pyriform, any laryngeal penetration, any laryngeal aspiration, and so on. Of course, any videoendoscopy, you will expect a lot of crying. So you have to have a glimpse of what's going on very quickly because of the crying attack that the baby is going through. Management is directed to the cause. If there is an organic cause, cleft lip or palate, bilateral vocal fold paralysis, subglottic stenosis, subglottic hemangioma, tracheoesophageal fistula, and esophageal atresia, and so on, the management is directed if there is organic. For us as a phoniatrician, I would go ahead to reduce the motor sensory based feeding difficulties by the external stroking on the external and internal cheeks, using the upper lips and lower lips and the tongue and the assisted jaw. Like Fusil et al., the Journal of Pediatrics, this systematic approach for doing the exercises, oral motor exercises for the lips and tongue and the jaw exercise. The advantages: reduce length of time to transition to full oral feeding in preterm infants and increase overall intake and higher breastfeeding rates. Oral motor program by the pacifier, also it has an impact, positive impact on reducing the stress and reduces defensive behaviors during the feeding time and reduces hospital chain.
الوقت خلص بس.
دقيقة فاضل دقيقة واحدة. Latching difficulties are dealt with our brilliant lactation consultants dealing with the tongue tip and so on, tongue tip tie and cleft palate, volume of milk and so on, with the nursing supplemental, compensatory stretches that we used with our NICU patient, and actually she was out of the NICU after 3 months, proper positioning with adjustment of the pace, adjustment of the volume and thickeners. And then, like this baby, also we followed the compensatory maneuvers with the oral sensory motor exercises. Out there are a lot of tools for the motor sensory exercises, icing and ice pops, and we use the 0 laryngeal size mirror. Actually, you have a metal spoon in the NICU kept in the freezer, so it makes the same idea, the spoon or the laryngeal mirror. Using the massage of the cheeks with the tether or with certain tools. This patient is your patient, Dr. Mariam. She was teaching her mother, I was teaching her mother all through the program to carry on the program at home using the utensils. These are the soft bristles and the brushes and the tactile input with the grabber, and learning to bite and chew later on. And then these are the animal tips you can use for texture adding. With the texture grabber with some food you can add. These are textured spoon. You can also use them with vibratory handles or without. Tongue protrusion or tongue thrust, you can use straws as soon as possible in order to prevent the tongue thrust. And tongue lateralization and tongue mobility upwards is very important for all of these tongue disorders. And believe me, at the end, it pays off. This patient was spitting and gagging and vomiting, but the final end, I got a nice kiss and a hug from her, and she ended very beautifully. Thank you so much.
دكتورة سامية, thank you very much. أنا حقيقة لازم يعني praise what you have done on the years for the swallowing problem. قبل احنا كنا في الأنف والأذن بنجد صعوبة بالغة في التعامل مع العيانين بتوع السوالينج بروبلمز دول, وكنا يا اما بنروحهم يا اما بنوديهم النيورولوجي وحظهم. يعني الحقيقة الدكتورة سامية في عين شمس in Egypt and maybe in the Middle East as well, she made نقلة نوعية في المانجمنت of the swallowing, and this الحقيقة thank you very much for that.
تلمستك يا دكتور أسامة.
العفو يا فندم.
انت النائب بتاعي الاساسي. انا كنت امتياز عندهم شهرين، هو اللي علم لي انف واذن.
شكرا جزيلا يا دكتور سامي. شكرا.